Welcome, and with this lecture, we're going to begin looking at the urinary system today. So, when it comes to the urinary system itself, it's a relatively simple system as far as the anatomy goes, but its function is vital to the survival of the individual, and its normal processes are quite extraordinary in considering what it actually does. And so it filters essentially all of our blood 24 hours a day, 7 days a week, 365 days a year. And in so doing, it's going to take roughly 200 liters or so daily and filter out all of the toxins, metabolic wastes, things that we've taken in throughout the day in excess, whether that's ions or water, and balances that all back out for our blood. In so doing, it's going to make sure that we keep the things that we need to keep, in other words, nutrients, hormones, the like that we want to maintain in the body, and just simply getting rid of the excesses that are there. And then at the same time, helping to balance out metabolic activities as far as acid-base balance in the body, water balance in the body, and as our ions fluctuate throughout the day as well. So lots of things going on, but when it comes down to it, we have kind of a relatively simple structure that's there. The kidneys do perform a little bit of a metabolic function as well. For the body, and in so doing, they're able to help to kind of the kidneys, in a sense, are a little bit along the lines of being kind of self-interested at times, in that it has the ability to sustain itself through maintaining blood pressure within the body itself, and it can maintain and help with the production of red blood cells as we need more of them. And it can also help to produce glucose when needed as well. As we talked about way back in the skin, the formation of vitamin D that we get from the skin is in an inactive form, and as it comes to the kidneys, it's going to then become activated as well. So lots of different things happening here. But the basic kind of anatomy that we have is that we have the kidneys. So we have two paired kidneys themselves. Each kidney has a ureter, and then both of those ureters feed down into the bladder. Unlike the bladder of, say, the digestive tract where we have the gallbladder, the urinary bladder isn't going to do anything with the urine once it actually gets there. It's just going to simply store it until it's ready to be released from the body through the urethra. So here we have the basic kind of setup that we have. And so two kidneys, one on either side. They are fed by a renal artery coming in. As we produce urine, those then flow out through the ureters and down to the bladder. And then the bladder fills and then drains out through the urethra as well. In terms of location, we have the two kidneys themselves are retroperitoneal. So they're behind the peritoneum themselves. The left kidney is a little bit higher than that of the right kidney. And so because of the liver there, the right kidney does get pushed down just a little bit as far as its location that is there. The two kidneys, as they are retroperitoneal, are basically sandwiched between the peritoneum of the digestive tract of the abdominal cavity and that of the posterior wall of the abdominal cavity itself. So they're really kind of stuck against that wall there, and mostly protected by the ribs as they come down, with just a little bit of the kidneys themselves kind of inferiorly coming down from the below the ribs themselves that are there. The kidneys do have a concave and a convex surface to them. That concave surface is where our blood vessels, the artery and the vein are entering into the kidney itself. And then we also have the ureter exiting there as well. And so in that hilum that is there, the hilus, this creates the region in that concave cave portion for all of those structures to enter and exit the kidneys themselves that are there. We also then have that's a bad drawing there. We have the suprarenal glands, or the glands sitting on top of the kidney that is there as well. And so we have our kind of cap sitting on top of the kidneys there as well. And then there's going to be a little bit of kind of adipose surrounding it as well, kind of keeping the kidney safe and secure inside there as well. So the kidney itself is a relatively delicate structure, but it is fairly well encapsulated by many supporting tissues that we have. And so kind of surrounding the kidney itself, we have the renal capsule. And so that's kind of the outer layer that is there. I just drew in the adipose capsule that surrounds the kidneys. This is there for cushioning, basically as we're doing things like running or jumping or horseback riding, motorcycle jumping, bike jumping, things like that. All of that can tend to put a tremendous amount of force and compression on the kidneys as we're kind of bouncing around. And that adipose capsule there is going to help with kind of keeping the kidney there and protected. And then we have the renal fascia, and that's then going to help to keep the kidney in its place and allow for it to essentially be kind of stuck against, what color do I have here? Kind of stuck down against the wall itself. And so there's an anterior portion and a posterior portion to that renal fascia that is there. We have all of the adipose surrounding the kidney there on that as well. And then right against the kidney, go with red there, we then have the actual covering to the kidney itself there. We have the capsule, so surrounding it directly on the surface there, we have that capsular space there as well. So things like muscle, things like adipose, although we're kind of not right at that portion, ribs coming out and protecting the kidneys themselves as well. They're nice and pretty well protected inside the body, and of course that left kidney is going to be a little bit more protected by the ribs than is the right kidney, as we see it there kind of hanging down below the ribs level, just a little bit extra on that one side. When we look at the inside of the kidney, we have a couple of different kind of general regions that we can see. We have the cortex that we have, and then we have the medulla. So we kind of have the inner portion and the outer portion there, the inner portion being the medulla, the outer portion being the cortex that is there. And then from there, so if I draw a kidney here, something like so, and then we have not a square, but more of a triangular pyramid that is inside there as well on those. And so the pyramids themselves inside there, we then have in between the pyramids, we have the renal columns. And so those lie in between there, between those spaces that are there. And then the cortex is the outermost aspect, the medulla being the inner portion to it. And then again here, we're going to have artery, vein, and ureter coming out of the kidney there from the hilum itself as well. And so those structures there then kind of pull everything together, and essentially blood's going to come in, and it's going to make its way out towards the cortex. And then essentially when it comes to making urine, the urine's then going to be formed through the pyramids and in towards the renal pelvis to eventually exit as the urine leaving the ureters themselves as well. So inside the kidneys themselves there, we have this kind of renal pelvis that I just mentioned. And essentially the structure is going to be something like that. Down here we have the ureter. Here we have the pelvis. And then from that pelvis, it's going to extend up, and we're going to have some kind of major calyces. And then within that, we're going to have some minor calyces as well. So the minor ones down here, major here, and all of those, in a sense, as far as the urine is concerned, the urine is then flowing in towards the pelvis and then eventually down through the ureter there as well on there. And so the actual kidney that we have in here would be the concave portion there, kind of coming around. And those minor calyces are going to be coming right up towards the pyramids on the ends there. And then that urine again is going to flow out of the end of the pyramid. Oops, wrong color. Out of the pyramid and down into the minor calyx and then into a major calyx from there. And then once that urine actually exits the end of the pyramid there, we're going to have the final product, so to speak, for the urine that is coming out. So again, different picture, a little bit better than mine was there. And we have the red, the cortex out through here. We then have the entire portion here from the pyramid in, kind of in blue here now. This is all the medulla, so kind of the inner portion there on those. And then each of the pyramids is going to, the urine as it's being produced is going to make its way towards the end of the pyramid, which is called the papilla. And that little papilla there is going to have many, many openings in which the urine then flows out into a minor calyx. Multiple minor calyces join together to give a major calyx, and then the major calyces then drain into the renal pelvis. And then from the renal pelvis down through the ureter and on its way towards the bladder as well. So blood supply is fairly straightforward in terms of the supply into the kidneys themselves. We begin obviously at the abdominal aorta, and the renal artery is what's going to bring the blood into that hilum of the kidney. So we're going to head towards the concave portion of the kidney and make its way into the actual kidney from there. We have a large amount of blood flow that comes into the kidneys off of the aorta. So they are relatively large blood vessels, and they're getting a quite a large quantity of our total output. And so if we said that our cardiac output was 5250 milliliters per minute, roughly 1200 of that is coming just to the kidneys themselves. So a large amount of blood flow, and a large amount that is going to then allow for the best amount of filtration that we can. And so as it comes into the kidney, we're going to branch and branch and branch and branch. And so this is essentially at the deep medulla. And then here we are out in the cortex. So as blood is flowing in and it's going from a segmental artery to a lobar to an interlobar to an arcuate that is there, and then to an interlobular, and then afferent arterioles, we're entering into that cortex at the arcuate artery, and inside that cortex is where we're actually going to do the filtration in the glomerulus. Blood flows through that glomerulus out through an efferent arteriole, and then we're going to come back in through the peritubular capillaries and the vasa recta. And so then our cortex basically ends there. And we're going to reverse the process in a sense for coming back out of the kidney, going through veins that have essentially the same name as the way that we went in. And so in through the interlobular, arcuate veins, interlobar, and then the renal vein and on out. To eventually drain into the vena cava itself. So pretty good branching is occurring as we go in through the kidneys themselves of all of those blood vessels on their way in. The nephron is essentially the functional part of the kidney. This is the filter portion of the kidney. This is where we're going to make sure that we get rid of all of the waste and make sure that we pick up all of the things that we need to reclaim so that we can do reabsorption on the substances that are inside our kidneys as well, kind of running through them. And this all begins at the glomerulus. And so the nephron itself kind of begins at this glomerulus. And so if we were to kind of draw a rough kind of structure there, we have something like this for an individual nephron. That's there. Blood vessels come in. We have our afferents and our efferents going back out. That is there. And the first kind of portion of filtration occurs here in this Bowman's capsule. And so inside the space that is there, this is the space where we're catching everything that we just filtered out of the blood. And when it comes to the filtration that is occurring here, we have fenestrated capillaries. Those fenestrated capillaries are going to allow just about everything to come out through the filter, except for proteins and cells. And so the large proteins of the blood, as well as red blood cells, white blood cells, are going to be left inside the blood vessels as they leave the glomerulus itself. That's there. And so as the blood kind of comes out of the structure there and leaves, we have most of our filtrate is out, other than the amount of proteins and cells that are there, and then obviously some water and some other things that are dissolved in the water didn't make it through on that first pass. And so here we have our nephron, and so here we have the glomerulus. That glomerulus there, where the purple is, are the actual blood vessels that are coming in there, and so the components of our capsule is right in there. And the capsular space is right there. So that's where all of essentially the recently filtered urine is coming in. And then we move into what's called the proximal convoluted tubules. Convoluted because they go back and forth and back and forth. And then we come down to the loop of Henle. We have a descending loop and then an ascending loop. The descending loop and ascending loop also have kind of a difference in terms of their makeup, in that we have a thin segment and then we have a thick segment as well. And so the actual cells that are lining those segments there are slightly different between the two that are there. And we'll talk about the differences in terms of what gets collected there in terms of reabsorption, and what happens in the thin segment versus the thick segment as well. So up through the ascending limb, we come back again by that glomerulus, and we're now going back into a convoluted tubule, this one now being the distal convoluted tubule. From there, we end up into the collecting duct, and then eventually out of the system from that point on. And so eventually exiting the pyramid, and then into the minor calyx, major calyx, and renal pelvis from there. So inside that glomerulus that we have there, we have a few different things kind of going on inside the glomerulus. So we have blood vessels And so we have our capillaries that are coming along. So we have our fenestrated capillaries. And then on top of that, we have what we call a podocyte. And so we have this kind of big cell, give it a nucleus inside there. And this podocyte has, as the name implies, little foot processes. And it's going to look kind of like a jellyfish or something there. And those little podocytes that it has there, the cells there, has these little foot processes on it. And mine looks more like a jellyfish than it does look like an octopus for there. But these little foot processes go out and cover the capillary. In between those foot processes, we end up with, and so like another one would be coming in from here and so on. And we end up little spaces inside there. And these are the filtration slits. And in between those filtration slits, this is where the filtrate coming from our capillary is going to kind of slide past, so to speak. And so as it makes its way in through there. So slightly different picture here. So now we have the capillary. And you can see the podocyte here is surrounding it. It has its little foot processes surrounding there as well, creating those little slits in between. Another different picture here, and this one kind of shows better all of those filtration slits as they lie in between the little foot processes themselves. And so when it comes to urine production, it's coming out into this capsular space through all of those little foot processes, all those little filtration slits, and essentially coming into the proximal convoluted tubule from that capsular space that's there. And so coming in, we have afferent arterial bringing in essentially high pressure blood. It goes back and forth and back and forth and back and forth in there, and then leaves through another arterial. So we're not done on the arterial side here. Those vessels are going to continue on down, and they're actually going to eventually come back down and meet up with the tubules themselves so that we can reabsorb the nutrients that we needed to for the urine, so that we're not losing nutrients in there. So we've got plasma on this side. That high pressure pushes it through the membrane of our blood vessel. So we have our fenestrated capillaries here. So the little openings there are fenestrations. Blood goes through, and out the other side, in a sense, comes urine as it's making its way through there. So we're going to make sure that, oops, wrong color. We're going to make sure that red blood cells aren't going to make it through there. So they're going to be too big to make it through the spaces that are there. We're going to have our kind of white blood cells do a lymphocyte there on there. And so we have different white blood cells. They can't make it through there. And then protein. We're going to stop those for the most part making through the membrane there so that we ensure that we don't have any kind of overlap of substances getting out that we don't want to make it through that membrane at all. So the renal tubule begins at the proximal convoluted tubule, and that proximal convoluted tubule has on it the ability to, and we're going to kind of sum it down to some specific things. So the renal tubule here is going to reabsorb water and solutes. The majority of what's coming out is water, though. And so water is our main component that's going to be extracted here. And the majority of the solutes that are coming back in are going to be almost everything that we just filtered back out. So it's kind of like we threw everything out, and then we're going to pick what we want to come back in terms of the filtrate there. It's kind of like cleaning out your house. And instead of just kind of deciding first what you want to get rid of, we're going to take everything out of the house and then put back in only the things that you want to keep. That's there. Everything else that doesn't come back into the house is going to be lost. That's essentially going to be waste that is there. The loop of Henle, once again, is going to continue to reabsorb water, especially in terms of that descending loop. And so the portion that is near the proximal convoluted tubule is going to continue to reabsorb water. And so water is going to continue to be reabsorbed as we move down that descending loop. They're primarily made up of the thin segment that is there. The distal portion, the thick segment, is then going to become impermeable to water. So water in that distal end is not going to get reabsorbed. Instead, it's going to be the solutes. So we're going to pull the solutes back in, and we're going to leave the water there. And so the effect here is that, as if we were to look at kind of the tubule itself here, and kind of draw the tubule in, this is our proximal convoluted tubule, this is our distal convoluted tubule. As we're going along there, the urine itself is essentially, or the fluid that's inside there is becoming more and more concentrated as we go down. And then on the way back up, it's going to become less and less concentrated as we make our way back up. And so we go from essentially a low concentration to a high concentration as we move down through the tubules themselves. And so that process is going to allow us to create a gradient that we're going to need to be able to create the type of urine that we need in terms of the amount of concentration that's there. So do we need dilute urine or do we need concentrated urine? Are we essentially hydrated or dehydrated on the two ends of the spectrum that's there? So it's a fairly complicated system, as we can see here. Lots of capillaries surrounding our tubules themselves there, so it makes it kind of almost difficult to kind of follow the pathway here. But here we come out of the, let me find a better color here, maybe. A better color there. We come out of the capsule into the proximal convoluted tubule, go back and forth on there. We're going to eventually come down the loop of Henle, back up the loop of Henle and into the distal convoluted tubule. That distal convoluted tubule comes back by and eventually comes into the collecting duct as it leaves the kidneys from that point on, in a sense, and we create our final concentration down that collecting duct that is there. So we're going to have relatively low concentration up here, and we're going to have high concentration down here. And that's going from the cortex into the medulla of the kidney that is there. And so we're creating that gradient of concentration as we've moved through the structures in the kidney itself there. So in order to do kind of different types of reabsorption and secretion, we need to have different types of cells available for that process there as well. And so when it comes to our tubules themselves that are there, in that last portion of the distal convoluted tubule, where we're moving into the collecting ducts that are there, we have these what are called little connecting tubules as well. And in there, we have two different types of cells. We have our intercalated cells, and then we have principal cells. Intercalated cells are going to, in terms of their function, is going to be the place where we determine acid-base balance. And so essentially, are we concerning ourselves here with hydrogen ion concentration inside the kidneys themselves? Do we need to get rid of more hydrogen ions, or do we need to get rid of more bicarbonate, depending upon whether we're in an acidic or a basic situation metabolically in the body itself? The principal cells are going to deal with salt balance. One of the two majors that we're going to look at are sodium and potassium. levels that are there, and then also dealing with water concentration as well. And so we're going to balance out the water by moving sodium and potassium in different directions along the tubules themselves there. So kind of water and salts kind of go together, and where one goes, the other one is essentially going to follow. When we look at the nephrons, in that last image that we saw there, we saw that one of the nephrons was kind of longer than the other one. And that's because we have two different types of nephrons. And so we have cortical nephrons, and then we have our juxtamedullary nephrons. The cortical nephrons are short. They're basically only in the cortex, and our juxtamedullary nephrons are much longer. The portion that changes in terms of the size is the loop of Henle. And so depending upon whether those loops are really, really long, in a juxtamedullary one, they're going to invade all the way down into the medulla. These ones also have very long, thin segments. So we've got a lot there in terms of the thin segments go. That being said, the majority of all of our nephrons are cortical. So we have more cortical nephrons than we have of our juxtamedullary, and that's essentially because we're well hydrated. We don't have to create such concentrated urine all the time. And so the long juxtamedullary nephron, the relatively short cortical nephron, as we see them there. And so the medullary or the cortical nephron just barely going into the medulla, and that juxtamedullary nephron going far down into the medulla itself, so that as our filtrate here is coming down through the collecting duct, we can determine our final concentration all the way up to the concentration that we get here at the bottom of the loop of Henle of a juxtamedullary nephron. The capillaries don't end in the glomerulus. We do have capillary beds that come down along all of the nephron as well. And so in the glomerulus, we have a set of capillary beds, and this is where we do our primary filtration. And then we have the peritubular capillaries. The peritubular capillaries are going to be where, rather than doing filtration, here we're doing reabsorption and secretion of waste products out into the urine itself that we're creating. That's there. So coming into the glomerulus, the capillary bed is fed by an afferent arteriole, and so coming in, we have an afferent arteriole, and then going out, we have an efferent. And then this here being our Bowman's capsule, and essentially our filtrate, our urine being created from there, and then that Bowman's capsule continues on from there as well on there. And so comes in that efferent arteriole is then going to continue on down and follow the tubules. And so it's going to make its way down along the tubules. And so this part of the capillary bed that we have is what we call the peritubular capillaries. And so the peritubular capillaries begin from the efferent arterioles. They make their way down with the proximal convoluted tubule, the descending loop of Henle, ascending loop of Henle, and then back up into the collecting duct that is there in the distal convoluted tubule that's there. So they're all around and clinging to the adjacent renal tubules that are there. And so if the tubule is here, our capillary is here. And on those juxtamedullary ones, we also have blood vessels that essentially connect both sides. And so this is what we call the vasa recta. And so the vasa recta, as it comes in there, tubule goes up to our capsule. And then this is our efferent, and then our afferent. The whole thing is the peritubular, and then the vasa recta are those connecting ones in between there. And those are going to connect the two sides that we have there. So here again, kind of the vasa recta create a ladder, and we'll talk about the purpose of having that ladder there on those juxtamedullary ones compared to the cortical nephron, where the peritubular capillaries just kind of go back and forth in kind of a no apparent reasoning to the movement of across there. They're just simply um, making it so that they're completely surrounding the tubules that are there. So when it comes to the kidneys are going to do filtration. And I liken this kind of filtration to essentially the differences between in a coffee maker. And so when we have a drip coffee maker, kind of your usual coffee maker at home, gravity is what's pulling the water through the filter. So we create the hot water, pour the water over the coffee grounds, and gravity pulls that coffee down through the filter itself. But that's just a relatively small amount of pressure pulling that down. We've basically just got gravity pulling them through there. If we want to kind of force the issue in a sense, rather than using gravity, we could use like an espresso maker or even like a Keurig, where we're going to force the water through the pod or the filter under a higher pressure. And so it's going to be faster in terms of the filtration, and it's going to be potentially more efficient as well. So blood pressure coming into the kidneys is going to drop pretty dramatically as we come into there. So from the renal arteries at a pressure in the neighborhood of 95 millimeters of mercury to the renal veins of under 10 millimeters of mercury as they leave there. So high pressure coming into the kidneys and basically low pressure as they go out. But the important aspect there is that we have a high pressure coming into the kidneys themselves. And that high pressure is what's going to allow us to filter out the blood when we need to. That high pressure is maintained in a couple of different ways. And so we have the afferent arterioles that are coming in, and the afferent arterioles are going to help to kind of smooth out the pressure. And so as we look at kind of the pressure coming through an artery, our pressure is always kind of going up and down with each contraction of the heart, especially in those larger arteries that we have there. The afferent arterioles are going to help to kind of keep those fluctuations in pressure under check. As well, when we do things like stand up, sit down, lay down, as those fluctuations in pressure occurs there for body position, they're going to help with that process as well. The efferent arterioles are also going to help in pressure, except for they're going to help to create a back pressure. So they're going to essentially, as they cause backup, this is going to reinforce that high glomerular pressure. This is going to increase that pressure so that as blood's coming in through the afferents and coming into the capsule that's there, and then going out, those efferents can essentially kind of push back, so to speak, and allow for that pressure to be maintained. And at the same time, it makes sure that as these efferents then become the peritubular capillaries, that the pressure continues to kind of fall, so that we don't have a high pressure inside the peritubular capillaries either. And so part of this process is maintained by the juxtaglomerular apparatus. And so where the distal tubule is going to come back past the glomerulus, we have this juxtaglomerular apparatus itself that's there. And so we have the afferent arteriole coming in, we have structures that are inside there, and part of its jobs is going to be kind of twofold, but they're both related to maintaining blood pressure. Oops, I thought I had a picture there. So it's going to produce renin as a hormone, and then it's also going to work as a mechanoreceptor that is there as well. So we have the ability to monitor the amount of pressure that's kind of coming into the system itself that's there. And so inside the juxtaglomerular apparatus, we have two types of cells that are there as well. One are the macula densa cells, and these are going to be the ones that are basically monitoring what's coming in through those capillaries that are there. So chemoreceptors, osmoreceptors, we're looking at the actual content as it comes into the kidney themselves. And then we have mesenglial cells. The mesenglial cells are going to have contractile properties, and they're going to be able to influence the pressure as it's coming in to maintain that capillary filtration that we need at basically a constant pressure. We don't want those fluctuations in the pressure themselves there. And here's the picture that I was referring to. So the afferent arteriole comes in. We have our juxtaglomerular cells that are there. We have our macula densa cells that are there as well. And the macula densa cells are looking at the content as they're coming through that distal convoluted tubule. The juxtaglomerular cells are looking at the pressure and being able to monitor that pressure as it comes in through that afferent arteriole that is there. Next time around, we'll continue to look at the glomerular apparatus that's there and continue on through the kidney.